brings back so many memories. And humble because on this very stage, great people have lectured. I don't know whether I could be bracketed with them. And I'm really, really honored to be here. Anesthesia is a subject which very few people know. We get into the newspaper only when a patient of ours dies. Nobody, they say anesthesia complication, patient died, administered overdose. The overdose and a word ತುಂಬಾ overuse ಮಾಡ್ತಾರೆ personally. They don't understand that now we have all studied medicine for 5 years, done our post-graduation. It's a very difficult course and we know what we are doing. But I must also confess to you that I am most ignorant about anesthesia itself in the sense I can administer anesthesia. ನಾನು ಈಗ ಲಾಸ್ಟ್ 1980 ಇಂದ ಅಡ್ಮಿನಿಸ್ಟರ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. But we still don't know how anesthetic agents act, some of them. How do they produce unconsciousness? ನಮ್ಗೆ ಗೊತ್ತೇ ಇಲ್ಲ ಅದು. There's very little research in that because brain is involved and brain research is very little. So I am going to take you through, like sir took us through the journey of the science forum. I'll take you through how it happened. It's actually funny, sometimes serious. I hope you'll enjoy that. That was the time first general anesthesia was administered. Before that, this was the technique used for anesthesia. Hit the patient on the head. Many times surgery was successful, patient would not wake up because the man holding this hammer would have hit the patient so hard. And after that, too many unsuccessful surgeries, our surgeons said, now anesthesia is illa. So, they tried other methods like alcohol, narcotics. It's not a human developmentally. Alcohol has come in very, very early, even before anesthesia. I don't understand the need for alcohol to come before anesthesia. Operation is not but alcohol not a So they used alcohol to, those of you who, whatever is your favorite portion, you know the effect. At some stage, you could be even operated upon. ಯಾಕಂದ್ರೆ ಕೆಲವರು ಬಿದ್ದುಬಿಟ್ಟು ಫ್ರಾಕ್ಚರ್ ಮಾಡ್ಕೊಂಡು ನೆಕ್ಸ್ಟ್ ಡೇ ಬರ್ತಾರೆ ಗೊತ್ತೇ ಆಗಿರಲಿಲ್ಲ ಅದ ಅನಸ್ತೀಸಿಯಾ ಎಲ್ಲ ನಾನು ಮಾತಾಡೋದು ಬಟ್ ದೇ ಟ್ರೈಡ್ ದಟ್ ಆಲ್ಸೋ ಅಂಡ್ ಹ್ಯಾಲುಸಿನೋಜನ್ಸ್ ಇದೆಲ್ಲ ಮ್ಯಾರಿಜುವಾನಾ ಗಾಂಜಾ ದೀಸ್ ವರ್ ಆಲ್ಸೋ ದೇರ್ ಫಾರ್ ಟೈಮ್ ಇಮ್ಮೆಮೋರಿಯಲ್ ಅಂಡ್ ಆಲ್ಸೋ ದೋಸ್ ಡೇಸ್ ಅವರ್ ಸಾಧುಸ್ ಹ್ಯಾಡ್ ಸರ್ಟಿಫೈಡ್ that if you want to attain nirvana, if you want to see the Lord, this is the agent which will take you on top. So there was somebody smoking marijuana was not considered as a bad man. Now they do, they even arrest you. But there was a clear-cut license from the religious heads. And also they tried other methods. Like if you put a rubber band on your finger, after 5 minutes it becomes numb. So they thought they could operate during that period. That is compression. And the other extreme was they would bleed a person so much that you would lose consciousness and then operate on you. Obviously most of them would have died because the blood loss, at that time blood transfusion was not there. So that is how it started. And we have now inhalation anesthesia, master kortive, local anesthesia. We popularly in anesthesia circles there is a joke saying that there was a VIP politician who came. He said, local anesthesia operation ಮಾಡ್ಬಿಡ್ತೀವಿ. Hey, local ಬೇಡಪ್ಪ ಇಂಪಾರ್ಟೆಂಟ್ ತಗೊಂಡ್ಬನ್ನಿ ನಮಗೆ. ಆ ಥರದ್ದಲ್ಲ ನಾನು ಹೇಳೋದು. Local anesthesia where you inject and operate on the patient. And intravenous, we inject. And those of you who are undergone anesthesia here will know, we anesthesiologists have a favorite pastime. Can you count 1 to 10? ಅಂತ challenge ಮಾಡೋದು. As if it's a mathematical equation, which only Einstein could have solved. 1, 2, and 3, 13 seconds maximum. Because by 13 seconds, the drug reaches the brain. That is called arm to brain circulation time, by which the person will become unconscious. So we have intravenous. And also I will take you through a very important journey in anesthesia called neuromuscular blocking agents. Okay? And also we have anesthesia machines. Whatever physics chemistry we learned here was extremely useful for anesthesia. I still know Charles' law, Boyle's law, Gay-Lussac's law, Poisson's law. Ella got to even other serious academic question. But I know about it. So we need that because we use compressed gases, we vaporize liquids into vapors, partial pressure ST to vapor, atmospheric pressure ST then the filter vapor. Because when I give 100% oxygen, I am giving atmospheric 1 bar, that is 760 millimeters of mercury. So we need to know physics. Anesthesiologist has to be a jack of all and also a master of all. So we need to know everything, and I am sure Lakshman, we worked together for many years. He is a wonderful surgeon. For a wonderful surgery, equally wonderful anesthesia is required. You know, for a science forum like this, if you don't have a media, multimedia hall like this, I'm showing it a it's a teamwork and good surgery. In fact, the best surgeries have been done in the recent years because of anesthesia. What are the things which are most important in the medical history? Antibiotics, anesthesia were very important to improve surgical field in a tremendous way. Can you believe now that we operate on patients who is awake, with his heart stopped, with the respiration stopped, who is on a heart-lung machine? If any one of you are interested, I will show you some videos. I am not going to show those videos today. I want to keep it basically simple. See, whenever we talk about anesthesia, I always go back to, these are the pictures of Sushruta. You know, this guy is operating on the chest, and he, I think, is an anesthesiologist. I know what I am So, this, why I have brought this in, those young minds here, whatever you do, please document. Now, the Indian brain is now document them. As a challenge, despite, as Professor told, publish, publish or perish. If you don't publish, you are nowhere in the international scene. We have to publish. Please, the students and youngsters who are here, publish whatever you do. Somewhere document it. ಇವರು ಸುಶ್ರುತ ಸಮೀಪ ಬರ್ತಿದ್ರು, ಬಟ್ ಅದನ್ನ ಸಂಸ್ಕೃತದಲ್ಲಿ ಬರ್ತಿದ್ರು, ಯಾರು ಓದಿಲ್ಲ. ನೀವು ಚೈನಾದಲ್ಲಿ ಕೇಳಿ, ವಿ ಆರ್ ದ ಒನ್ಸ್ ಹೂ ಡಿಸೈನ್ ಅನೆಸ್ಥೀಸಿಯಾ, ಅವ್ರು ಎಲ್ಲನೂ ನಾವೇ ಕಂಡಿದ್ದೀವಿ ಅಂತಾರೆ. ಅಂಡ್ ಅಮೆರಿಕಾ, ವೈ ಇಸ್ ಇಸ್ ಸಚ್ ಎ ಗ್ರೇಟ್ ಕಂಟ್ರಿ, is because people systematically documented. For anesthesia, America has given a huge amount of contribution. None of the mistake is it. Wonderful work is done, but not documented. I request all of you, wherever you have hope to publish, do it, please. If not either, these are the instruments in Chakravarthy Samhita. These are the instruments we still use. And see these, they were used as syringes. They would, these bulbs made of leather, they would fill medicines and inject. But documented modeling there. So I am showing this because the syringes are very important aspect for anesthesiologists. Syringe is our life. And of course, the Arabs also, they are nowhere better than us. They also did good work, but they also did not publish. But they used to use soporific sponge and that. They used to let the people inhale and do surgery. There is some documentation. But all these documentations are our hodgepodge, haphazard. But we must document better way. In Charles Darwin's autobiography, he writes, I quote, I also attended on 2 occasions the operating theatres in hospitals at Edinburgh and saw 2 very bad operations, one on a child, but I rushed away before they were completed. Nor did I ever attend again, for hardly any inducement would have been strong enough to make me do so. This being long before the blessed days of chloroform. The 2 cases fairly haunted me for many years. Those days, they used to fold the patients and then operate. And patients used to shout. There was nothing. What they used to do was, they used to give a piece of wood to bite on. Some people would bite through that wood with so much pain. That was the fate before anesthesia. But after, ether was the first anesthetic agent. I don't know whether it's available in the lab even now. It's now used as an industrial solvent. But those days, ether was first used as an anesthetic. But this word chloroform becomes so popular Even now when I talk to my patient, I'm going to give you a general anesthesia. They say, are you going to give me chloroform? Chloroform, we don't use it anymore. But it's very, very popular among lay public. Everybody talks about chloroform. And Bollywood has still not forgotten. You know, you saw the recently one movie, Houseful. Even there, that muscular guy, I forget his name, he puts the chloroform on a girl's face, anesthetizes her and takes her away. This is all the Bollywood has learned anesthesia. And I want to seriously talk to one of the directors and say, show some good aspects of anesthesia. We are all professionals, we do good things, so that. But chloroform became very, very popular. You know why? Because Queen Elizabeth was anesthetized during her delivery, and she made a rule that every woman in UK who gets a delivery should get chloroform. And that anesthetist who did John Snow and that, he became a very rich man, you can imagine. And if they make a rule like that in India, I would have taken all of you on a helicopter and given my lecture. I would have been so rich. There is another one. This is the experience of the patient. I mounted the bed and the cambric handkerchief was placed upon my face. The bed was then surrounded by 7 men and my nurse. Through the cambric I saw a glitter of the polished steel knife. A silence ensued. Oh, what a terrible suspension. When the steel was plunged into the breast, I screamed that lasted unintermittently during the whole time. That was how surgeries was done. But now, it's so beautiful. The patient lies down, sleeps, when he wakes up the operation is over. And it is not just simple operations. Phenomenally different operations. Where we go into the chest, we go into the brain, anything. When I give a general anesthesia, you can operate on any organ that you want. But we have small changes that we make for different anesthesia. This is a great man who served Thomas William Gray Morton. He was an American dentist who used chloroform like this on October 15, 1846. And even now we celebrate it as the World Anesthesia Day. And this was done in the Mass General Hospital. Those of you who have gone to Boston, next time when you go, please go to Mass General Hospital, ask the security, the reception there, I want to go to the Ether Dome. It's an auditorium even now kept in pristine state, and I think I have a photo. This is a drawing of the first anesthesia. This is the same, this is the Ether Dome, see this? So this is mortal, and this is a mortal within that one eye. I went there, I went and asked, can I see Ether Dome? He said, are you an anesthesiologist? I said, yes. From which country? I said, I'm from India. He took me himself. He opened the next to this dome is the psychiatry ward. It's a functional hospital. This dome, even now, people sit there and listen to lectures, and that is the beauty, greatness of the Americans keeping this. This is a landmark tower for anesthesia. There is a board saying that people from far and wide will come and see this hall because this hall has changed the lives of many individuals. It has changed my life. I love to be an anesthesiologist because I give pain relief, which I think is greatest. I always tell we give something called as labor analgesia, where we do an epidural injection for a woman in labor. I tell them, when I come and do the injection, you will be free of pain. Some women, before they are actually going to labor, they laugh at me and say, you talk as if you are God. I said, I am not God, but I can do this. But when I go, when they are in labor pain, they say, oh my God, give me some pain relief. I give this and they get pain relief. Then you tell me who's the God. I'm not telling anything. Okay? So that is the beauty of pain relief that anesthesia can give. So we have a lot of anesthetic agents that we currently use, which are very safe and for the patient. Of course, anesthesiologists are blamed as the biggest culprits spoiling the environment. We make holes in the ozone layer because we use fluorinated carbons for our anesthetic agents. So these agents can cause, that is a problem. This is John Snow and this is Queen Victoria, and Queen Victoria's 7th child, Prince Leopold, was born under chloroform anesthesia. So this man is a very, very important stalwart in anesthesia. We in India have something to contribute to anesthesia. In late 1800s, 1900, in India, Hyderabad, the Nizam of Hyderabad called scientists from UK and conducted what is called the Chloroform Commission. This Chloroform Commission 1 and 2 was done in India. It is probably one of the earliest scientific test done that was done to see, administering chloroform, a lot of patients died. They wanted to know what caused the death. Did the heart stop first or the respiration stop first? So what did they do? They put a patient, gave anesthesia. One person was only watching the respiration, another person was watching the pulse. Surprisingly, in this commission, they found very few patients dying. Then at the time they didn't realize, now we know, because if you had two people monitoring the patient, it's very rare for the patient to die, because they could change immediately. Our first few lessons about monitoring was learned there. Now if you come to my operation theatre, I hardly ever look at my anesthetic gases. I'll show you some of the videos where anesthesia workstation is like a cockpit. We always compare anesthesia to flying aircraft. Induction of anesthesia is like taking off. And maintenance of anesthesia is like cruising. And removal of the tubes, waking up the patient is like landing. As you know, most accidents take place during takeoff or landing. Even in anesthesia, most accidents take place during induction or at the time of reversal. But if you come now, we have computerized gadgets all around us. Sometimes it is difficult for me to get out to have a cup of coffee because there is the instrument all around me. I cannot get out of the operation theatre. We have so many instruments. So there is a huge change in anesthesia from the days of Martin. We also use the additives in anesthesia, and we use needles, syringes, opioids, blood transfusion, now a lot of imaging, echocardiography, all that we use. So the modern day anesthesia is safe. Those of you who are safety personnel or quality people here, you talk of 6 sigma. Anesthesia now fits into 6 sigma. If safely administered, there will not be a death, 1 in a million. Okay? So we also, like the aircraft theatre, we follow the checklist. Before the patient comes, we ask the patient, what is your name? What surgery are you undergoing? Some of the patients ask, if you don't know what is my name and what surgery I am undergoing, why did you bring me into the operation theatre? We tell that we make sure that you are indeed the same Krishnamurti that I want to operate. There may be one more fellow, one Krishnamurti has a tonsil, other fellow needs a bypass surgery. If I do tonsil for a patient requiring bypass, he is not going to even, bless me any time. So we have a checklist now. We make sure the side, in US, our actress Sridevi's for mother was operated on the wrong side of the brain because the surgeon came with a wrong MRI. In that MRI, he saw the problem was on the right side of the brain. He went into the right side of the brain, there was no tumor. Then he was surprised, then they checked it was wrong. So it can happen anytime. If something can go wrong, it will. Therefore, we always make a huge, strict, disciplined approach to identifying the type of surgery, side of surgery. It's very important to knock out the wrong eye. The diseased eye is this side, and if this is a healthy eye, you knock it out. He cannot even see who caused this problem. So like I was saying, these are the halogenated hydrocarbons which we use nowadays, and currently we use sevoflurane, desflurane, disoflurane. These are agents which don't get metabolized in the body. It's very important for us to administer an agent which does not get metabolized. If it gets metabolized in the body, then it causes a harmful effect. So we administer agents which don't get metabolized. And local anesthesia started with cocaine. Cocaine used to be chewed for its effect on the brain. And now they have different forms of inhaling cocaine. And that was applied by a surgeon called Halsted. He thought that if it can help cure the toothache, why not I use it for surgeries? Simon Freud and Carl Kohler anesthetized eyes with cocaine. Cocaine eye drops were used, and they felt that eye could be operated upon. If there was a foreign body, it could catch out. And it is extensively used in breast surgery. This gentleman Halsted has a surgery called Halsted surgery. It's an extended radical mastectomy for cancer of breast. He did with cocaine. But unfortunately, he also tried some cocaine on himself and became an addict. So a lot of anesthesiologists try these funny things. They administer a little to see how it feels, and they also get addicted. So we have to be extremely careful. That is why I have a phobia to these drugs, hallucinogenic drugs, even in small quantity. If I undergo a surgery, I am sure I am not going to take the hallucinogenic drugs because I am extremely scared. It should not be even once unnecessarily tested. And also, these workers became addicts. They were cured. And this gentleman gave a local anesthetic block for his own appendicectomy operation. How beautiful is that? And this was what ischemia, what I was talking about. They used to put a tight band and tighten it and operate on the hand. Spinal anesthesia, many of you may have heard. Spinal anesthesia is one of the most popular anesthesia even today. And this cocaine was injected into spinal canal by James Corning. This was probably the first spinal anesthesia. Imagine somebody injecting a drug into the spinal canal. Spinal canal is a very pristine, virgin area. It's like the top of Himalayas. Nobody has ever gone there. You go there and put a drug and get a paralysis of both the legs and then recover. And the first man, also August Bayer, tried the spinal anesthesia. He gave for his assistant gave for him. And both of them developed the first complication known as a headache after spinal anesthesia, post-spinal headache. But you must admire the guts of these people to, they didn't undergo surgery. They just gave a block for themselves. It's, I think, hugely contributive to our anesthesia. And these are the first two cases of post-spinal headache. And also, spinal anesthesia became very unpopular in the UK because some of the patients died. It was because of varicity. See, again, we are coming back to the chemistry and physics aspect of it. We need to know the specific gravity of the cerebrospinal fluid, and we need to know the specific gravity of the fluid we administer. Suppose this is a hypobaric solution. You inject, assuming that it's going to go down, it's going to go up. And it's going to go and paralyze the brain. If local anesthetic goes to the brain, the person will immediately become unconscious and all brain functions will cease. So they understood about the varicity, and there was another Rose and Bully case. The 3 patients after the spinal anesthetic never walked again. They had paraplegia, or both the limbs were blocked forever. And people said that spinal anesthetic should be banned. Then they realized that these ampules were stored in phenol, and the glass with the ampules had some cracks. Phenol had seeped into the spinal anesthetic, and phenol is a neurotoxic substance. We use phenol even today to burn some nerves which cause pain. For those of you who are not familiar with anatomy, this is the spine, vertebral body. This is the spinal canal into which the spinal cord is there. Spinal cord is there, brain, the Chakravarthy. And at every level, beautifully there will be nerves going to each part of the body. So from the top to bottom, you can decide where you can block. And what a beautiful gift of God the human body is there. When we block the nerves in the thoracic area, the respiration doesn't stop because the muscles diaphragm is supplied very high up. Probably ಆಗಲೇ ಗೊತ್ತಿತ್ತು ಅನ್ಸುತ್ತೆ ಸ್ಪೈನಲ್ ಅನೆಸ್ಥೆಸಿಯಾ ಕೊಡಬಹುದು. ಅದರಿಂದ ಈ ಫ್ರೆನಿಕ್ ನರ್ವ್ನ ದೂರ ಇಟ್ಟಿರೋಣ ಅಂತ. So we don't get breathing problem at all. So this, why I am showing you is, this spinal cord is surrounded by a sheath called the dura mater. Between the dura and the spinal cord is the cerebrospinal fluid. And this fluid is throughout the brain, all around the brain, coming down into the spinal cord. That is why when you get a head injury, you don't get as much injury as you actually should. You remember, in the skull, there is no space for the brain to move, very little, millimeters. So when you get an injury, the amount of injury could be phenomenal. But nature has provided covers for all vital organs. Heart has a cover, pericardium, and there is a pericardial fluid. That is why you see, even if somebody hits on the chest, heart rarely ruptures. It doesn't, it is protected. And by physics we know that when you apply pressure on a liquid chamber, immediately the pressure is dissipated. It doesn't go to one point. So similarly, now ಎಷ್ಟು ಜಂಪ್ ಮಾಡ್ತೀವಿ, ಬೀಳ್ತೀವಿ ಅದೆಲ್ಲ but spinal cord rarely get, rarely you hear of people who fell down and broke their back and stuff. But how many times we fall since our age, childhood age, but spinal cord rarely gets damaged because it's protected. What we do is we put a needle through the back and go up to this point. This is muttala, spinal cord muttala. Touch the spinal cord, they will have a nerve problem. It is so sensitive. Spinal cord is packed with nerves. Touch madre yada one kada one nerve will get damaged. Patient will not feel the skin or will have burning sensation. So we do that. Epidural is one step beyond that. We don't epi outside, dura, epidural. So we give injection here. These are two common techniques even now used. And I am proud to say that in the world, we have the largest series of epidural anesthesia for cardiac surgery. If you Google my name, you will find that awake surgery done in Bangalore, 5 years and Chakravarthy. Because we have done that and we are very few. And for this reason, I have lectured in many places like Harvard, etc. only for administering this epidural anesthesia. So we administer epidural anesthesia. It's about 100-year-old. It's even now commonly administered. The advantage of epidural is that any level you can administer. Chest surgery, neck surgery, abdomen, limb, anything you can do. Spinal very below the umbilicus. You cannot give above because the spinal cord substance is there. Spinal cord chuchbabu, I have already told you about that. So, and America actually was slow to popularize epidural, but they very strongly supported epidural. So, it's an important contribution of the country to anesthesia. Intravenous anesthetic agents we routinely use, and it was also in 1600s, in the 17th century, that they started using the epidural. This is Timothy Clark, and they used the toad bladder. We had already finished inventing all this. Systems had already shown from leather bags we could make, but documentation is from Europe. Unfortunate, because we didn't document it early enough. And they tried injecting all kinds of things, wine, opioids, milk, broth, alcohol, beer and statistics. I think only those were available. Because they didn't know, they were just experimenting. And they observed various phenomena occurred over and over again, which held me in doubt whether such operation could be ever safely employed. It would require previous alteration of the injection. So they realized some change has to be made, and we did make changes, and we have a lot of anesthetic agents. We routinely use intravenous anesthetic agents. It's very safe and very pleasant, and typically when we administer anesthetic, the person will start hearing curially growing. It's some like a psychedelic movie, and they pass. And that moment of loss of consciousness is a permanent loss from your life. You will never be able to recall what happened during the anesthesia. We ourselves don't know how it produces. There are theories saying the anesthetic agents, because of the pressure, because of the fat content in the brain, dissolves in the brain selectively until theoretically aware, but we really don't know the exact hypothesis how anesthetic agents act. So we use balanced anesthesia. What is balanced anesthesia? Anesthesiologists are like cooks. So you can't make a dish only out of milk and left. And now ಒಂದು ಸ್ವಲ್ಪ ಅದು ಒಂದು ಸ್ವಲ್ಪ ಇದೆಲ್ಲ ಹಾಕಿ ಮಿಕ್ಸ್ ಮಾಡಿ ಈ ರೊಟ್ಟಿನಲ್ಲಿ ಮಸಾಲ ಪುಡಿ ಮಾಡ್ತಾರಲ್ಲ. So that tastes so wonderful because there's a lot of so many things. Anesthesiologists also do. That is why most anesthesiologists are good cooks. I am also one of them. Any one of you, if you want to risk it, you can come and taste. So we always try this combination. A little bit of sedative, little bit of medicine to suppress the brain, little bit of muscle relaxant, ಎಲ್ಲ little bit ಕೊಟ್ಟು patient ಮಲಗಿಸ್ತೀವಿ. ಕೆಲವರು ಹೇಳ್ತಾರೆ, sir, I am not afraid about surgery, I am afraid about anesthesia. I said, yes, you better be afraid, because I also don't know how anesthetics work. Oh my God, no, just kidding, don't worry. So in 30 years I have this time, you always patients wake up. So you are the man who put me to sleep. Don't use the term, putting to sleep another veterinary surgeon's model. Now we wake you up. You say that I am the man who wakes you up. So a lot of people are mortally scared of anesthesia. And especially, I was on a TV show, I was to talk about safety of anesthesia. The TV called me. I am used to that. ಹೋಗಿದ್ದೆ. ಬೇರೆ ಡಾಕ್ಟರ್ಸ್ ಬರ್ತಾರೆ ನೋಡಿದ್ರೆ ಯಾರು ಇಲ್ಲ. ಇನ್ನೂ 3 ಫ್ಯಾಮಿಲಿ ಬಂದರು. ಯಾರಂದ್ರೆ ನನ್ನ ಮಗನಿಗೆ ಅನೆಸ್ಥೆಸಿಯಾ ಕೊಟ್ಬಿಟ್ಟು ಸಾಯಿಸ್ಬಿಟ್ರು ಸರ್. ನಾವು ಬಂದಿದ್ದೀವಿ. ಸರ್ ನಮ್ಮ ಮಗುಗೆ ನೀವು ಪೇಪರ್ ಓದಿರ್ಬೇಕು ಸರ್, ನಾವೇ ಸರ್ ಅವರು ಅಂತ. ಸರ್ ಹಾಳಾದ ಅನೆಸ್ಥೆಸಿಸ್ಟ್ ಕೊಂದಾಕ್ಬಿಟ್ರು ಸರ್, ಹಿಂಗೆಲ್ಲ ಮಾತಾಡ್ತಾರೆ. ಆಮೇಲೆ ಆ ಥರ ಎಲ್ಲ ಮಾತಾಡೋ ಅವಶ್ಯಕತೆ ಇಲ್ಲ. On the table death ಆಗೋದು ಉಂಟು, ರೇರ್, ಬಹಳ ರೇರ್. On the table death ಆದರೆ it is not only anesthesia which is the reason. That is exactly the purpose why I am talking to you. Is there are so many things which happen. I will explain to you which can cause death, including surgery. In fact, we don't cut, surgeons cut. So, you know what can cause death. Cutting injection in a solve madutta, cutting madutta, all of you agree? I will tell Lakshman that you all agree. So sodium pentothal for a long time used, it was a barbiturate. Barbiturate was used and it, for many years it is even now available but we don't use. We use propofol. Anybody knows propofol? Michael Jackson, he put a dot on this so that people would never forget. That person was taking it to get sleep. Can you imagine? And he had a doctor also to that. So propofol is the milk injection. Whenever I say this is a milk injection, oh, you are giving same thing that Michael Jackson took. Yes, but that was administered by an idiot doctor, but I am not that. So you will get up for sure. So propofol, always anesthetic drugs are misused. And many people don't know that we arrange drugs before taking surgery. And they are all labeled. And sometimes we have people who come and they take away, steal those drugs thinking they will produce some psychedelic effect. When I was doing post-graduation, a doctor, he took it intramuscular. And I finished my case and I was going up. He was typically showing signs of what we call a neuromuscular blockage. Neuromuscular blockage is breathe and play it. I said, I knew him. I asked what happened. And he was not able to talk. Blabber. Then I asked him, why did you know that ampule looked golden in color? I thought that would produce some hallucinations. He was actually, may have hallucinated, he was reaching God and I brought him down and now I don't know where he is. He is only one guy who must have experienced a near-death experience because of the anesthetic drug. So we use other drugs. A lot of college students know. They're all misused anesthesiology drugs because they produce either memory loss or hallucination or some kind of delusion, unrealistic experiences. They do that. Now we use total intravenous anesthesia, no inhalation, because we are going to face the problem of environment issues because our fluorinated hydrocarbons are going to make the whole ozone layer and stuff. We are going to stop probably. In the next few years it will stop. So, how much can an anesthetized patient move? Can anybody guess? He can't even move a little finger. We give them a medicine which paralyzes them. Okay? That is where the trick starts. Always they ask me, how are you going to give anesthesia? I am going to make you sleep and I am going to give a drug by which you will not be able to breathe. Oh my God, then what happened? No, I will put you on a ventilator, I will breathe for you. What if you go out for a tea? No, the ventilator will breathe, he knows I am outside. Oh no. And just today, but we will always be there. Two of us are there with the patient all the time. If my ventilator doesn't work, theoretical hypothesis, it's like both engines seizing of an aircraft. It's going to be a spiral all the way down. But we have many ways. We can breathe with the hand, we can breathe with the mouth. The anesthesia has become very safe now. So please remember, if the patient under anesthesia, he can't even make a little finger move, you can imagine about his respiration. Far away. He can't breathe. So I tell my patient, once we give you anesthesia, you are my baby. I have to take care of you. I will not go anywhere. Many a times it has happened situations that there have been family emergencies. Could not leave the patient and fly. Surgery has to get over, patient has to wake up, he should be safe, then only I can go. And again, in our medical community they say, doctors are cursed, they cannot attend to their own family. Neuromuscular blocking agent was one of the most important inventions in anesthesia and surgery. Once they discovered the neuromuscular blocking, it was used as an arrow poison. You must have seen in some of the movies, they show you the African people let go of an arrow, it hits the deer, after 5 minutes it starts limping and falls. That was a medicine called as urare. And they used it for hunting. This urare became curare, and even now we use modifications of curare. So it is very important that heart of a cat continued to beat 2 hours after this drug was administered. That means essentially that animal doesn't die, but it can't move. Like an anesthetized animal, I was telling you, even the deer cannot move its little toe. So they cut the deer, and that's how it was used. And Benjamin Murali did an experiment and showed that if an animal was given curare injection and if its ventilation was supported, it would wake up again. This was a golden moment in anesthesia. Because then we could not open chest, we could not open abdomen. So superficial. Why we can't open abdomen? If I open the abdomen without anesthesia, the pressure of the muscles will make the abdominal contents herniate. Ella horrible bidutte. You Lakshman anta operate ಮಾಡಬೇಕಂದ್ರೆ relaxation ಪಡೆಯ ಸ್ವಲ್ಪ ಅಂತಾರೆ. ಯಾಕಂದ್ರೆ ಎಲ್ಲ intestines ಹೊರಗೆ ಬಿಡುತ್ತೆ. So there is no way you can sew the abdomen back. That's why the relaxant has come, and it's very, very useful. And Benjamin Murali observed that an incision was made in the windpipe, and through that lung was inflated for 2 hours with a pair of bellows, and the ass held up her head, looked around, and this said ass from the final dissolution. She rose up, walked about. She seemed in neither agitation nor pain. This is probably one of the most important experiments in the human way. We know that you can make a hole in the breathing pipe, breathe for somebody artificially, and then the person wakes up. And also this is one of the early anesthesia machines which we used. A lot of people have contributed to anesthesia machine, and now we have changed tremendously. And those of you who are interested in biology might understand, when we breathe for somebody, how does carbon dioxide get eliminated? Oxygen game problem illa. Air is but carbon dioxide, they go into what is called as carbon dioxide narcosis. They will become unconscious. They will, anesthetic may go, but the carbon dioxide is so high, they can't breathe. It's like choking. So we made carbon dioxide absorber, which is called soda lime. Sodium bicarbonate, calcium carbonate, it absorbs carbon dioxide. So again, chemistry here. So I made my professor TGR very proud when I told him, sir, you all kalputidini nanna. Iglaru kaltella budaya. So we also managed the airways. Slowly over time, we took control of patients' respiration, patients' ventilation. Even now, a lot of intensive care are run by us. Now we have intensive care run where patients are artificially ventilated, they are paralyzed or sedated. We put tube into the patient's heart attack, if they drown, if they hang, or if they get pneumonia. All those conditions we put them on ventilator. So anesthesiologists have become champions of that, and we still do that. It has nothing to do with anesthesia, unconscious model. But because of our knowledge in ventilating, we continue to do that. So we have a lot of instruments. We use a lot of endoscopes, bronchoscopes, and we use martivi. So which was unheard of. Now post-graduation you won't believe, we used to give anesthesia, the only monitoring we had was a finger on the pulse. So Professor Balazo, finger on the pulse. So finger on the pulse. Now we have everything electronic. So we become so sophisticated, it has actually increased the safety of the patient. And ventilator, it's very interesting. In 1957, in Copenhagen, there was a polio epidemic. Okay? Now polio is eradicated nearly from all countries, definitely from India. Very proud to say that. They use bellows, and medical students were paid some money to ventilate patients. Ventilate and ಅವ್ರಿಗೆ ಟ್ಯೂಬ್ ಹಾಕ್ಬಿಡೋದು, ಅವ್ರು ಒಂದು ಬ್ಯಾಗ್ ಕೊಟ್ಬಿಟ್ಟು ಅದನ್ನು ಕುತ್ಕೊಂಡು ಓದ್ತಾ ಇರಬೇಕು. ಅದನ್ನು ಮರ್ತ್ಬಿಟ್ರೆ ಆ ಪೇಷಂಟ್ಸ್ ಕೂತ್ಕೊಳ್ಬಿಡ್ತಾರೆ. ಸೊ ಅವ್ನು ಮಾಡಬೇಕು ಒಂದು 2-3 hours ಅಷ್ಟೇ. ಅದ್ರ ಮೇಲೆ ಅವ್ನು ನಿದ್ದೆ ಮಾಡ್ಬಿಡ್ತಾನೆ, ಪೇಷಂಟ್ ಹೋಗ್ಬಿಡುತ್ತೆ. ಅದಕ್ಕೆ ಅವ್ನು ಕಳಿಸ್ಬಿಡೋರು. ಆ ಥರ ಮಾಡಿ ಇದು ಮಾಡಿದ್ರು. Then it is the Dutch who invented the ventilator. Even now they have a very prominent role in the ventilators. They have most sophisticated ventilator. They made what is called as iron lung. I'll show you the picture. This is a medical student who is ventilating a child. You see that? A tube going into the trachea, breathing pipe, and this man has a bag and he is ventilating. So after some time he won't be smiling, he may be sleeping. Adike we don't ventilate with hand anymore. Ella ventilator ventilate. Yakandre kaiyalli ventilate ಮಾಡುವಾಗ we don't rhythmically breathe. Sometimes if you are sleepy, you may breathe slowly. If you are angry, you may breathe fast. That you must understand there is a patient connected to that tube. So this is the Copenhagen. This is the iron lung. Can you see this photo? This is the epidemic, and see how many iron lungs are there. Patient would be placed in a chamber, and that chamber pressure would be reduced, negative pressure. We do exactly reverse of that. We put a tube into the mouth, give positive pressure, intermittent positive pressure ventilation. However, they did it, they soon found that you were very uncomfortable. Imagine the patient, if the patient became unconscious or vomited, that would go into the lungs because it was sucking, not pushing. So, but this was an important step in our anesthesia life. Because like I told you, I can handle a defibrillator, I can handle a pacemaker, I can have an echo machine, I can have syringe pumps, and monitoring devices, there are real time, and we have electronic data, is innumerable. Now, I cannot go on talking to you about what we do because it's a big, huge chapter. So, anesthesia is now heavily. Having said this history, brought you to the present day, I will quickly tell you how a normal anesthetic works. Normally, patient comes to the hospital. This is the patient, this way I am going to talk to you about admission to discharge. This is how the patient comes, and on arrival, we admit the patient to the ward, and we talk to the patient, and we always ask them, when did you have your food lost? Please, when you are going for an operation, Dr. Hello Martruno, milk is also considered solid food, okay, for 6 hours. So, as usual, coffee operation 6 hours delay. Nil by mouth. Yake? Because the food is in your stomach and there is acid in your stomach. The acid will curdle the milk. All small particles are there. When I give anesthesia, I told you nothing can move. When I am ventilating, the stomach is abdomen olage stomach. The colloquially stomach is full hotel. I am talking to the stomach, etc. Otherwise, you put gas and the food can come back. It's not vomiting. Vomiting is dura outbuildutte. Idu vayu olage bandubidutte food. That will go into the windpipe, and that is one of the commonest causes of death in pregnant women. So, you should not eat anything, milk or oral. NP won't order for it, dievitu follow ಮಾಡಿ. ಆಮೇಲೆ age, sex, occupation ಎಲ್ಲ ತಿಳ್ಕೊಂಡು we ask you, are you diabetic, are you hypertensive? Each of those conditions has a problem. When you get under anesthesia, it is for you a point of no return. At that time I cannot ask you, in diabetes ಇದೆಯಾ ಅಂತ ಆಲ್ರೆಡಿ ಮಲ್ಕೊಂಡ್ಬಿಟ್ಟಿರ್ತಾನೆ. Diabetes ಇದೆ ಗೊತ್ತಾ, blood sugar 50 ಆಗೋಯ್ತು, ಯಾಕಪ್ಪ ಡಯಾಬಿಟಿಕ್ ಅನ್ನೋದು ಅಂದ್ರೆ did you ask the patient diabetic ಅಂದ್ರೆ ಮರ್ತ್ಬಿಟ್ಟೆ ಅಂದ್ರೆ ಈಗ ಎಷ್ಟು ಬಿಟ್ಟು ಕೇಳಕ್ಕಾಗಲ್ಲ. So we have to ask everything, we get all the details, and then detailed examination by an anesthesiologist, we assess the fitness. How do we assess fitness? Suppose you come for an operation, you ಏನು ಕೆಲಸ ಮಾಡ್ತೀರ, ಏನು ಮಾಡೋದಿಲ್ಲ ಮ್ಯಾಕ್ಸಿಮಮ್ ಅಂದ್ರೆ ಏನು ಟಿವಿ ರಿಮೋಟ್ ಆಪರೇಟ್ ಮಾಡ್ತೀವಿ ಸರ್, ಅಷ್ಟೇ ಎಕ್ಸರ್ಸೈಸ್ ಅವ್ರಿಗೆ ಅಂತ ಹೆಂಗೆ ಅಸೆಸ್ ಮಾಡೋದು? ವಿ ಹ್ಯಾವ್ ಟು ಅಸೆಸ್ ದೆಮ್ ಪುಟ್ ಥ್ರೂ ಟ್ರೆಡ್ಮಿಲ್ ಟೆಸ್ಟ್. ಅಲ್ಲ ಸರ್ ನಾನು ಬಂದಿರೋ ಹರ್ನಿಯಾ ಆಪರೇಷನ್ಗೆ ನಾನು ಟ್ರೆಡ್ಮಿಲ್ ಯಾಕೆ ಸರ್ ಮಾಡ್ತೀರಾ ನೀವು? Because under anesthesia we can go to extremes of situation. Blood pressure may go high, it can go low, heart rate can become slow. Are you able to tolerate at the silkobetu? Adike we do all the tests. Many a time patient ಏನು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ಸರ್, ನಾನು ಏನು ಲೈಫಲ್ಲಿ ಹಾಸ್ಪಿಟಲ್ಗೆ ಬಂದಿಲ್ಲ ಅನ್ನೋರಿಗೆ you realize that he has got hypertension. ಅದು ಟ್ರೀಟ್ಮೆಂಟ್ ಶುರು ಮಾಡೋಣ ಅಷ್ಟರಲ್ಲಿ ಸರ್ ಥೈರಾಯ್ಡ್ ಸ್ವಲ್ಪ ಲೋ ಇದೆ ಅಂತಾರೆ, ಆಮೇಲೆ ಬ್ಲಡ್ ಶುಗರ್ ಜಾಸ್ತಿ ಇದೆ. ಏನ್ ಸರ್ ಇಲ್ಲಿ ಬಂದ ತಕ್ಷಣ ಇಷ್ಟೊಂದು ಕಾಯಿಲೆ ಕೊಟ್ಬಿಟ್ರು, ಇತ್ತಪ್ಪ ಮೊದಲದು ನಾವು ತಿಳ್ಕೊಂಡು ಈ ಶುಡ್ ಥ್ಯಾಂಕ್ ಅಸ್ ಫಾರ್ ದಟ್ ಫ್ರೀ ಅನೆಸ್ಥೆಟಿಕ್ ಚೆಕ್ ಅಲ್ಲಿ ಮಾಡಿದ್ದೀವಿ ಇದೆಲ್ಲ. ಇದರಲ್ಲಿ ನಾವು ಆಲ್ಸೋ ಆಸ್ಕ್ ಯು, ಆರ್ ಯು ಟು ಕನ್ಸ್ಯೂಮ್ ಆಲ್ಕೋಹಾಲ್, ಆರ್ ಯು ಸ್ಮೋಕರ್, ಇವೆಲ್ಲ ತಿಳ್ಕೊಬೇಕು. ಯಾಕಂದ್ರೆ ಸ್ಮೋಕರ್ ದೇ ಹ್ಯಾವ್ ಟೆಂಡೆನ್ಸಿ ಟು ಕಾಫ್, ದೇ ಹ್ಯಾವ್ ವೀಸಿಂಗ್ ಪ್ರಾಬ್ಲಮ್. ಇವೆಲ್ಲ ಒನ್ಸ್ ದೇ ಗಿವ್ ಅನೆಸ್ಥೆಸಿಯಾ, ಇಫ್ ದ ಪೇಷಂಟ್ ಸ್ಟಾರ್ಟ್ಸ್ ವೀಸಿಂಗ್, he will in no way help you. ನಾನೇ ಮಾಡ್ಕೋಬೇಕು ಏನಾದ್ರು. ಲೈಕ್ ಐ ಟೋಲ್ಡ್ ಯು, he is my baby. I have to give ಇನ್ಹೇಲರ್ ಕೊಡಕ್ಕೆ ಬಾಯಿ ಪಫ್ ತಗೊಳಪ್ಪ ಅನ್ನೋಕ್ಕಾಗಲ್ಲ, ಬಿಕಾಸ್ ಅವನು ಉಸಿರೇ ಆಗ್ತಿಲ್ಲ, ನಾನು ಉಸಿರಾಡೋದು ಅವನಿಗೆ. ಸೊ ಇಟ್ಸ್ ಅನ್ ಎಕ್ಸ್ಟ್ರೀಮ್ಲಿ ಡಿಫಿಕಲ್ಟ್ ಪಾರ್ಟ್. ಇನ್ ಅನೆಸ್ಥೆಸಿಯಾ we always say prepare at the peace time so that you don't bleed at war. So we always follow that. If somebody in my department doesn't follow, I take a great anger about that. ನನಗೆ ಗುಡ್ ಮಾರ್ನಿಂಗ್ ಸರ್, ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್ ಹೇಳಿದ್ರೆ ಪರವಾಗಿಲ್ಲ, ಬಟ್ ಪೇಷಂಟ್ ಕರೆಕ್ಟಾ, ಡ್ರಗ್ಸ್ ಕರೆಕ್ಟಾ, ಅವ್ರದ್ದು ಡಿಸೀಸ್ ಕರೆಕ್ಟಾಗಿ ನೋಡ್ಕೊಂಡಿದ್ದೀರಾ, ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್. ಸೊ ನೀವೆಲ್ಲಾದ್ರೂ ಹೋದ್ರೆ ಅನೆಸ್ಥೆಸಿಯಾಲಜಿಸ್ಟ್ ಎಲ್ಲ ಕೇಳ್ತಾರೆ, ಎಲ್ಲ ಹೇಳಿ, ಕೇಳಲಿಲ್ಲ ಅಂದ್ರೆ ನಾನು ಹೇಳಿ, ಅವ್ರು ಕೇಳ್ತೀನಿ ಯಾಕೆ ಕೇಳಲಿಲ್ಲ. ಸೊ ಹಿಸ್ಟ್ರಿ ಇದು ತುಂಬಾ ಇಂಪಾರ್ಟೆಂಟ್. And allergies. Some of the people are allergic. Suppose, of course, a lot of people say I'm allergic to penicillin and that. That's hare kalam kase. Aವಾಗ ಅದೇನಾಗ್ತಿತ್ತು ಮೋಸ್ಟ್ಲಿ ಎಲ್ಲ ಕಂಟಾಮಿನೇಟೆಡ್. ಕೆಲವರು I'm allergic to my wife ಅಂತಾರೆ. ನಾವೇನು ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಅಲ್ಲ ಹೇಳೋದುಂಟು are you allergic to anything ಅಂದ್ರೆ yes ಅಂತ. So, but medicines allergy. Because some of the medicines that we use in anesthesia are also related to some of the medicines we give. Like for example, xylocaine, local anesthetic kododu. It is similar to some of the neuromuscular blocking agents, some of the antibiotics. Adrinda, you should always tell your doctor. Second, you should always, doctor ನಮ್ಮ ಮನೆಯಲ್ಲಿ ಯಾರಿಗೋ ಒಬ್ಬರು ಆಪರೇಷನ್ ಮಾಡಿದ್ರು, ಅವ್ರ ಅನೆಸ್ಥಿಸಿಯಾ ಪ್ರಾಬ್ಲಮ್ ಆಗಿತ್ತು, ಇದ್ದಿದ್ರೆ ಹೇಳಿ. ಯಾಕಂದ್ರೆ there are some familial problems which cause problems in anesthesia. We need to know so that we can avoid. One thing is which is uncommon in India, overseas it is common, is hyperparaxia, fever. Anesthesia ಕೂಡ fever ಶುರು ಆಗುತ್ತೆ and it's mostly fatal. ಏನು ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಅದಕ್ಕೆ ಯು ಹ್ಯಾವ್ ಟು ಗಿವ್ ಅಸ್ ಸಮ್ ಪಾಯಿಂಟ್. ನೀವು ನಮ್ಮ ಕಡೆಯಿಂದ ಮುಚ್ಚಿಟ್ಕೊಳ್ಳೇಬಾರ್ದು. ಲಾಯರ್ ಹೇಳ್ತಿದ್ರು ಪರವಾಗಿಲ್ಲ, ಡಾಕ್ಟರ್ ಹೇಳಿ. ಯಾಕಂದ್ರೆ ಮನೇಲಿ ಹೇಳ್ತಾರೆ ಡಾಕ್ಟರ್ಗೆ ಲಾಯರ್ಗೆ ಎಲ್ಲ ನೀವು ಹೇಳಬೇಕು ಅಂತ. ಲಾಯರ್ ಹೇಳಿದ್ರು ಪ್ರಯೋಜನ, ಯಾಕಂದ್ರೆ ಅದೆಲ್ಲ ಬೇಡ ಸುಮ್ಮನೆ ಅಂತಾರೆ. ಬಟ್ ನಮಗೆ ಎಲ್ಲಾನು ಹೇಳ್ಬಿಡಿ ದಯವಿಟ್ಟು. ಬಿಕಾಸ್ ಯು ನೀಡ್ ಟು ನೋ, ಬಿಕಾಸ್ ಐ ಕಾಂಟ್ ಟೇಕ್ ಹಿಸ್ಟ್ರಿ ಆಫ್ಟರ್ ಗಿವ್ ಯು ಅನೆಸ್ಥೀಸಿಯಾ. ಸೊ ಆಫ್ಟರ್ ದ ಚೆಕ್ ವಿ ಚೆಕ್ ಬ್ಲಡ್ ಪ್ರೆಷರ್, heart, lungs, everything we check, and we also check your airway. You know, one thing which many of you may not be aware is I need a person with a normal airway. Normal airway ಅಂದ್ರೆ ಏನು ಸರ್ ಅಂದ್ರೆ ನೋಡಕ್ಕೆ ನಾರ್ಮಲ್ ಆಗಿರಬೇಕು. ಕೆಲವರಿಗೆ ಈ ಚಿನ್ನು ಇದು ರಿಸೀಡಿಂಗ್. ಸೊ ಅಂಥವ್ರಿಗೆ ನಾವು ಎಂಡೋಟ್ರಾಕಿಯಲ್ ಟ್ಯೂಬ್ ಅಂತ ಟ್ರೈಕಿಯಾದಲ್ಲಿ ಹಾಕ್ತೀವಿ. ಹಾಕೋದಕ್ಕೆ ಕಷ್ಟ ಆಗುತ್ತೆ. ಹಾಕೋದು ಕಷ್ಟ ಆದಾಗ ಯು ಮಸ್ಟ್ ಅಂಡರ್ಸ್ಟ್ಯಾಂಡ್ ವೆನ್ ಐ ಆಮ್ ಡೂಯಿಂಗ್ ದಟ್ ಅ ಪೇಷಂಟ್ ಇಸ್ ನಾಟ್ ಬ್ರೀದಿಂಗ್ and I am not yet breathing for him. That is the period when he is what we call apneic. ಉಸಿರಾಡ್ತಾ ಇರಲ್ಲ, he is paralyzed, he is unconscious, ಏನು ಗೊತ್ತಿರೋದಿಲ್ಲ. ನಾವು ಟ್ಯೂಬ್ ಹಾಕಕ್ಕೆ ಆಗಲಿಲ್ಲ ಅಂತಂದ್ರೆ ಬಹಳ ಕಷ್ಟದ ಸಿಚುವೇಶನ್. ಈಗ we use bronchoscopes, we do that away, they are very good, and I must tell you that in my 30 odd years of anesthesia, in the recent years we have never failed to put a tube because we are so supported by infrastructure in our hospitals now. So we also examine the spine. ನಿಮ್ಗೆ ಯಾವಾಗಾದ್ರೂ ಕಾಲ್ ಪ್ರಾಬ್ಲಮ್ ಆಗಿತ್ತು, ಸಯಾಟಿಕ್ ಆಯಿತು, ಅಥವಾ ಒಂದ್ಸರಿ ಕಾಲ್ ಬಿದ್ದೋಗಿತ್ತು, ಹೀಗೆ ಅಥವಾ ಥರ ಆಗಿತ್ತು, these things you need to tell a doctor who is planning a spinal anesthetic. We always see they stay at least 6 hours empty stomach and we consent. Who can give consent for others? Parents can consent for children below 18 years. ಇಲ್ಲಿ ನಮ್ಮಲ್ಲಿ ಏನಂತಾರೆ, ಅವಳದ್ದು ಏನು ಗೊತ್ತಿಲ್ಲ ಸರ್, ನಾನೇ ಸೈನ್ ಮಾಡ್ತೀನಿ ಕನ್ಸೆಂಟ್ ಅಂತಾರೆ ಹಸ್ಬೆಂಡ್. ವೈಫ್ ಸರ್ಜರಿ, ಇವ್ರೇನು ಕನ್ಸೆಂಟ್ ಕೊಡೋದು? ದಟ್ ಇಸ್ ನಾಟ್ ಅಕ್ಸೆಪ್ಟಬಲ್. ಸೊ ಎನಿ ಒನ್ ಆಫ್ ಯು ಲೇಡೀಸ್ ಅಂಡ್ ಇನ್ ಸರ್ಜರಿ ಇನ್ಸಿಸ್ಟ್ ದಟ್ ಯು ವಿಲ್ ಕನ್ಸೆಂಟ್. ನಿಮ್ಗೆ ಬೇಡವಾ? ಕೆಲವು ಸಲ ಏನಾಗುತ್ತೆ, ಟ್ಯೂಬೆಕ್ಟಮಿ ಮಾಡಕ್ಕೆ ಯಾಕ್ರೆ ಅಂತಾರೆ. ಟ್ಯೂಬೆಕ್ಟಮಿ ಮಾಡಿ ಹಾಕೋದು ಸಿಂಪಲ್ ಆಪರೇಷನ್ ಅಲ್ಲಪ್ಪ. ಆಮೇಲೆ ಯು ವಿಲ್ ನಾಟ್ ಬಿ ಏಬಲ್ ಟು ಕನ್ಸೀವ್. ನಾನು ಹೇಳ್ತೀನಿ ಮಾಡಿ, ಆಗಲ್ಲ. ವೈಫ್ ಹ್ಯಾಸ್ ಟು ಕನ್ಸೀವ್. ಸೊ ಅನೆಸ್ಥೀಸಿಯಾಗೂ ಕೂಡ ಕನ್ಸೆಂಟ್ ಕೊಟ್ಟಿರ್ತೀವಿ. ಆಟೋಮ್ಯಾಟಿಕ್ಲಿ ಆಪರೇಷನ್ ಅಂತ ತಕ್ಷಣ ಇವೆಲ್ಲ ಮಾಡ್ತಾರೆ ಅಂತ ಗೊತ್ತಿರ್ಬೇಕು ನಿಮಗೆ, ಅನ್ನೋಕ್ಕಾಗಲ್ಲ. ನಾವು ದೇರ್ ಆರ್ ರೈಟ್ಸ್ ಟು ಪೇಷಂಟ್ಸ್ ಅಂತೀವಿ. ಯು ಹ್ಯಾವ್ ಟು, ದೀಸ್ ಆರ್ ಯುವರ್ ರೈಟ್ಸ್, ತಿಳ್ಕೊಬೇಕು ನೀವು. ಯು ಮಸ್ಟ್ ಗಿವ್ ಕನ್ಸೆಂಟ್ ಫಾರ್ ಯುವರ್ ಓನ್ ಸರ್ಜರಿ. ಅಂಡ್ ಮೆನಿ ಆಫ್ ಯು ಆರ್ ಆನ್ ಲಾಟ್ ಆಫ್ ಮೆಡಿಕೇಶನ್ಸ್, ಬೀಟಾ ಬ್ಲಾಕರ್ಸ್, ಸೆಡೇಟಿವ್ಸ್, diabetic medications. We have to change those medications. So we always suggest ಒಂದು ವಾರಕ್ಕೆ ಮೊದಲು ಆಪರೇಷನ್ ಮೊದಲು ಬಂದ್ರೆ we will change your medications, make sure that you are safe for the operation, and then we'll take you. Please remember that and tell all the medications. And you should always say, any time in your life, have you taken the same tablet for 6 months? You should tell us. That is long duration. And have you ever got admitted to the hospital? You should tell us. Ever got operated? You should tell us. These are things which we need to know. And also, theatre bandmele, we do what is called as time out. This was new concept introduced by WHO, where we do the checklist. I think I have a video showing that. This is our operation theatre. See now, this is what I was telling. This is all hot from the shelf. Today I shot this video because I didn't want to download from the internet. This is the patient. Usually we put a binder on the patient, and this is my colleague anesthesiologist. She has an intravenous fluid, and this is my other senior colleague. He breathes ಯಾವಾಗಲೂ ಒಬ್ಬರು ಪ್ರಾಬ್ಲಮ್ ಆದರೆ ಇನ್ನೊಬ್ಬರು ಇರ್ತಾರೆ. So he has the sheet. He checks. Are you the same patient? Do you have the same problem? We have an ID band. ಅದನ್ನು ನೋಡಬೇಕು, ನಂಬರ್ ಚೆಕ್ ಮಾಡಬೇಕು. Make sure that there may be 2 patients by same name, so we should not miss out. So it's done quietly before any medication is given. ಕೆಲವು ಸಾರಿ ಏನಾಗುತ್ತೆ IV ಕಂಡೀಷನ್ ಕೊಟ್ಬಿಟ್ಟು ಹಾಗೆ ಯಾವ ಕಡೆ ಅಂದ್ರೆ ಲೆಫ್ಟ್ ತರ್ತಾರೆ. ಏನೇ ರೈಟ್ ತೋರಿಸಿ ಲೆಫ್ಟ್ ಹೇಳ್ತೇವೆ ಅಂದ್ರೆ ಸಾರಿ ರೈಟ್ ಅಂತ. So we get confused. So we need to ask before we give sedation. So he makes sure that we ask and then we give the sedation. And you see the patient is now awake. He has finished the checklist and that is the blood pressure cuff. That is automated. Every 3 minutes it will check the blood pressure and tell me. It will appear on my monitor and the patient comfortably lies down. You put a strap. If they put a strap on the operating table, don't get surprised. It is to prevent your fall. ಕೆಲವು ಸಾರಿ ಏನಾಗುತ್ತೆ ನಿಜನಲ್ಲಿ ಮನೇಲಿ ಮಗಿದೀವಿ ಅನ್ಕೊಂಡು ತಿರುಗಿಬಿಡ್ತಾರೆ. ಆ ಮಂಚ ಇರೋದು ಇಷ್ಟು ತಿರುಗಿದ್ರೆ ಕೆಳಗೆ ಬಿದ್ದುಬಿಡ್ತಾರೆ. You have heard in the press we saw that a pregnant woman fell off the table and her uterus ruptured. Baby died and mother died. How horrible is that? So fall prevention ಅನ್ನೋದು we always follow it very religiously. So bedding ಬಂದ ತಕ್ಷಣ we put a strap so that the patient would not fall on that. And this is the induction of anesthesia. The oxygen mask. Patient ಹೇಳ್ಬಿಟ್ಟು she keeps the oxygen mask. We have a technician who will help. Usually they are semi-educated people, but very smart guys. ಅಲ್ಲೇ ಇದು ಕಲ್ತ್ಕೊಂಡ್ಬಿಡ್ತಾರೆ. ಕೆಲವು ಸರಿ ಟ್ಯೂಬ್ ಸರಿಯಾಗಿ ಆಗಿಲ್ಲ ನಮ್ಗೆ ಹೇಳ್ಬಿಡ್ತಾರೆ. ಅಷ್ಟು ಡೇಂಜರಸ್ ಅವರು. ಸೊ ಮಾಸ್ಕ್ ಇಟ್ಕೊಂಡು ಇದು ಬ್ಯಾಗ್ ನೀವು ಇದು ಮೂವೀಸ್ ಅಲ್ಲಿ ನೋಡ್ತಾ ಇರ್ತೀರ. ಅನಸ್ತೀಶಿಯಾ ಹಿಂಗೆ ಕಂಡ್ಬಿಟ್ಟ ಅಂದ್ರೆ ಬ್ಯಾಗ್ ಸ್ಟಾಪ್ ಆಗಿರುತ್ತೆ ಮೂವ್ ಆಗೋದು. ಅದೆಲ್ಲ ಅಷ್ಟು ಸ್ಕೇರಿ ಇಲ್ಲ. We can be quite casual. You can see quite relaxed and this is the strap I was talking to you about. ECG ಬರ್ತಾ ಇರುತ್ತೆ. So we breathe. See, patient has stopped breathing. Just a while ago he was breathing. Now we are breathing for him. And ಇಲ್ಲಿ ಹಿಂದ್ಗಡೆ you will see, notice a ventilator. I will show you that. This is the senior man. He is administering the drugs. See, white milk injection I was talking to you about. We are administering now. That goes through in Fortis. So within 13 seconds the patients will be asleep and we go on talking to them so that they don't get petrified. You must remember one thing. You may be a big family going to the hospital. On the table you and I are alone. I always tell the people, ನೀವು ಇಷ್ಟು ಜನ ಇದ್ದಾರೆ ಅಟ್ ಸಂತೆ ಪ್ರಯೋಜನ ಇಲ್ಲ. You trust me because I am the only one who is going to hold your hand. ನೀವು ನನ್ನ ನಂಬದೇ ಇದ್ರೆ ಆಗೋದಿಲ್ಲ. ತುಂಬಾ ತೀರಾ ಕ್ವಶನ್ ಕೇಳಬಾರ್ದು. ಬೋರ್ಡಿಂಗ್ ಪಾಸ್ ಕೊಟ್ಟ ಮೇಲೆ ಇದಕ್ಕೆ ಪೆಟ್ರೋಲ್ ಹಾಕ್ತಿದ್ದೀರಾ, ಇದು ಎಷ್ಟು ಆಟಿಟ್ಯೂಡ್ ಹೋಗುತ್ತೆ ಕೇಳ್ತೀರಾ ಪೈಲಟ್ ಹೇಳ್ತಾರೋ. ಅದೆಲ್ಲ ಅರ್ಥ ಮಾಡ್ಕೊಳ್ಬೇಕು. ಕೆಲವು ಹೇಳ್ತಾರೆ ಕೆಲವರು, ಐ ಆಮ್ ಎಕ್ಸ್ಟ್ರೀಮ್ಲಿ ವರಿಡ್ ಡಾಕ್ಟರ್. I will answer your question. Doctor, how many such operations have you done? I have done many operations. Now can you give me an number? ನೋಡಮ್ಮ ನೀವು ಡೆಲ್ಲಿಯಿಂದ ಬಂದ್ರಿ, ಹೆಂಗ್ ಬಂದ್ರಿ, ಏರ್ಕ್ರಾಫ್ಟ್ ಬಂದ್ರಿ, ಕೇಳಿದ್ರೆ ಪ್ರಶ್ನೆನ ಬೋರ್ಡಿಂಗ್ ಪಾಸ್ ಕೊಟ್ಟರು ಆ ಸೀಟ್ ನಂಬರ್ ಕೂತ್ಕೊಂಡ್ರಿ. ಹಂಗೆ ಮಾಡಬೇಕಿಲ್ಲ. ಬನ್ನಿ ನೋಡ್ರಿ, ನಾವೆಲ್ಲ ಸೇಫಾಗಿ ಮಾಡ್ತೀವಿ. ಅಲ್ಲಿ ಪೈಲಟ್ ವಿಲ್ ಬಿ ಮೋರ್ ಕೇರ್ಫುಲ್ ಬಿಕಾಸ್ ಇದು ಏರ್ಕ್ರಾಫ್ಟ್ ಕ್ರಾಶಸ್ ಅವನು ಹೋಗ್ಬಿಡ್ತಾನೆ. ಅದರಿಂದ ಅವರು ಬಹಳ ಕೇರ್ಫುಲ್ ಇರ್ತಾರೆ. ವಿ ಆರ್ ಆಲ್ಸೋ ಕೇರ್ಫುಲ್ ಬಿಕಾಸ್ ದೇ ಆರ್ ರೆಪ್ಯುಟೇಷನ್ ಟು ಗಾಡ್. ಐ ಡೋಂಟ್ ವಾಂಟ್ ಟು ಕಮ್ ಇನ್ ದ ಪ್ರೆಸ್ ಟುಮಾರೋ ಇಂದ ಡಾಕ್ಟರ್ ಚಕ್ರವರ್ತಿ ಮಾಡಬೇಕು ಅಂತ. So this is the, I think that the repeat figure. Now the tube is, the patient is paralyzed and we have a mask ನೋಡಿ tube ಹಾಕ್ತಾ ಇದೆ ನೋಡಿ. Okay? See, you can see the patient made a small movement. ಕೆಲವು ಸರಿ ಆಗತ್ತಪ್ಪ, but nothing of that will be registered in the brain. The moment we give the milk injection, they will become unconscious. Okay? So if there is a need, see, he moved. If there is a need, the senior can help. ಬೇಕಾಗುತ್ತೆ ಕೆಲವು ಸಾರಿ. ಅದಕ್ಕೆ we are always true. ಇದು ನೋಡಿ, ಇದು ಟ್ಯೂಬ್ ಹಾಕಿದ್ದೀವಿ. We are connected to the breathing circuit and you can see the ventilator behind. Tell us. That's all Benjamin Murali ಅವರ ಸ್ವಲ್ಪ ಇದನ್ನ ನಾವೀಗ sophisticated ಆಗಿ ಮಾಡ್ಕೊಂಡಿದ್ದೀವಿ. So we fix the tube and the patient is anesthetic. After that, whatever we do to him will be pain free and it will be out of his memory. And then at the end, our operation ಮುಗಿತು. So we have this catheter is called a suction catheter. ನೋಡಿ, suction catheter. There's a negative pressure. It will suck the saliva and all those things. We remove the tube like that. Patient is already lifting hands. Now the awake. Normally ನಾವು put a tongue out ಅಂತೀವಿ. Not the tongue ಇದೆಯಾ ಇಲ್ಲ ನೋಡೋಕ್ಕಲ್ಲ. Sticking a tongue out is such a peculiar action. Nobody will ever forget. So he also put his tongue out and then he is completely awake. So I think then we give some oxygen so that the patient continues to breathe some oxygen because at the end there may be some deficiency of oxygen. Okay? And he is putting out the tongue. Tongue ಹೊರಗೆ ಬಂತು ಅಂತಂದ್ರೆ ನಮಗೆಲ್ಲ ರಿಲ್ಯಾಕ್ಸ್, ನಾವೆಲ್ಲ ಹೋಗ್ಬೋದು, ಟೀ ಕುಡಿಬೋದು ಅಂತ ಅರ್ಥ. So tongue ಹೊರಗಡೆ ಹಾಕಿರ್ಬೋದು. So this is the operation theatre and Currently, most of the hospitals have state-of-the-art monitoring or whatever. There are very, very good operation theatres. And I must tell you, we should all be proud about when we started bypass surgery, surgery ಬರೋರು ಎಲ್ಲ ಮಾಡಿಬಿಟ್ಟು ಡಾಕ್ಟ್ರೆ ನಮ್ಮ ರಿಲೇಟಿವ್ US ಇದ್ದಾರೆ ಅಲ್ಲೇ ಮಾಡ್ಕೊಂಡ್ಬಿಡ್ತೀವಿ bypass. ಅದಾದ್ಮೇಲೆ ಸರಿಯಪ್ಪ ಎಲ್ಲ ಇಂಡಿಯಾದಲ್ಲಿ ಬಂತು ಮಾಡ್ತಾ ಇದ್ರೆ ಡಾಕ್ಟ್ರೆ ಚೆನ್ನೈಯಲ್ಲೆಲ್ಲ ಚೆನ್ನಾಗಿ ಮಾಡ್ತಾರೆ ಅಂತ ಅಲ್ಲಿಗೆ ಹೋಗ್ಬಿಡ್ತೀವಿ. You must actually, Bangaloreans should thank Dr. Javali and our team because we made bypass surgery available to every common man in India and we have done thousands of them with very good success and we have pioneered some of the surgery because of the excellent operation theatre. So this is the operation theatre, then we transfer. See, you think that anesthesia tube takes the test and kelsa mugitu athara alla. I will have to transfer my patient. I will transfer the patient with the monitoring, whatever I have in the theatre, same thing. And then we transfer the patient. We all currently have an area called TACU, post-anesthesia care unit. Only the patients are monitored by nurses. It is under the sight and sound of anesthesiologist. Most of the problems I told you occur during landing. This is the time. After we have removed the tube, patient will become unconscious again or will not breathe well. So we monitor them for 2 to 3 hours and then send them to the ward. This is our recovery room. We have beds here and it's a semi-critical area. So it's better. And we discharge, we have got some select criteria how we discharge the patient and only when the patient reaches that score, the patient is discharged and usually, this Aldrich score and the modified Aldrich score, we use that. For hospital, whenever, nowadays we do the surgery in the morning, discharge the patient in the evening, day case surgeries. So we become so safe, so confident that our medicines will not act at home. But please remember, if you have an anesthetic, if you are going home, don't drive your car. Second, don't go near fire or any moving parts, mixie operate. Although you may feel top of the world, feeling good and that, don't do that because anesthetic still will persist for some time. At night, do not consume alcohol. ಇವತ್ತು ಒಂದೇ ದಿವಸ ಸಾರ್ ಅಂತಾರೆ ಹೌದಪ್ಪ ಇವತ್ತು ಒಂದು ದಿವಸ ನಾಳೆಯಿಂದ ತಗೋಬಾರದು ಅದು ಹಿಂದೆ ಬದುಕಕ್ಕಾಗೋದಿಲ್ಲ ಅನ್ನೋದು ನಾನೇ ಕೊಟ್ಟಿದ್ದೀನಪ್ಪ ಸಫಿಷಿಯಂಟ್ ಕ್ವಾಂಟಿಟಿ ಇವತ್ತು ನೈಟು ಕಳುತ್ತದೆ ಅಂತ ಹೇಳ್ತೀನಿ. So this is the recap of what we do and thank you very much.